Welcome to the funnel effect.
It's great to be here for this one. We've got a really fantastic topic today.
We really do. Today, we are immersing ourselves in a Viewpoint article titled Excimer Laser Coronary Atherectomy in Contemporary PCI. This was published in Eurointervention in March 2026, and it's authored by Dr. Alfonso Gerardo Roman and Dr. Mattia Bazile.
And it's such a compelling read because we're exploring a fascinating renaissance in heart medicine right now.
Yeah, specifically using ultraviolet lasers to vaporize blockages inside human arteries, which, just sounds like pure science fiction.
It does, but the premise here is very real and very grounded. Picture this. You have an occluded vessel, and the standard mechanical interventions like balloons or drills are physically incapable of crossing the lesion.
Right, they just hit a brick wall.
Exactly. So you need a way to modify that barrier without compromising the structural integrity of the artery itself.
But our mission today for you, the listener, goes way beyond just the mechanics of lasers. You might not be a cardiologist, but today you are going to understand how cutting-edge problem solving works in real time.
Because we're looking at how doctors literally update their rule books as technology and human experience evolve.
Specifically, we're looking at the shift from a classic, highly defensive rulebook known as the 5 S's to a completely new set of modern principles.
It really is a brilliant lens through which to view clinical evolution. Because, in any highly specialized discipline, those early protocols are inherently defensive.
They have to be. You're dealing with a novel, poorly understood tool inside a human heart.
Right. They are designed to mitigate risk. But as you accumulate decades of procedural volume, the relationship between the operator and the instrument fundamentally changes.
You start to see the nuances.
Exactly. The original guidelines, which prioritized absolute baseline safety, start to feel a bit restrictive. Operators start recognizing the physics of the tool, finding edge cases where the old rules actually hinder success, and they push the boundaries.
So let's ground this by looking at the reality of the hardware. We're dealing with ELCA. That stands for Excimer Laser Coronary Atherectomy,
Which is a percutaneous technique, meaning it's done through the skin to modify atherosclerotic plaques using ultraviolet laser energy.
But this is a technology with a rather checkered past, isn't it?
Oh, absolutely. The literature notes that coronary lasers were first conceptualized back in the 1980s, and those initial clinical outcomes were notoriously poor.
Because they were using the wrong kind of light. They were relying on continuous wave infrared laser systems.
Yeah, and the thermal kinetics of infrared energy fundamentally mismatched the delicate structure of a coronary artery. Infrared energy primarily interacts with tissue by inducing a rapid increase in temperature.
You're basically boiling the intracellular water to destroy the plaque.
That's exactly it. And the problem, as those early operators quickly discovered, is the sheer lack of thermal control. The heat radiates outward from the target, creating this wide zone of thermal necrosis that just destroys the adjacent healthy tissue.
And we are talking about a vessel that might only be 3 millimeters wide. So thermal injury is catastrophic.
It is. When you expose the deeper layers of an artery to uncontrolled heat, the vessel goes into intense spasm, the architectural layers can literally dissect or tear apart, and you risk acute closure.
So they were clearing the obstruction, but the collateral damage made the procedure clinically inviable.
The tool is just too destructive. But the paradigm shift, the catalyst for the modern era of ELCA, was the transition to the xenon chloride excimer laser.
Right, because the xenon chloride excimer operates on an entirely different spectrum. It emits pulsed ultraviolet light, specifically at a wavelength of 308 nanometers.
And that shift from infrared to ultraviolet completely alters the mechanism of tissue destruction. We move from thermal vaporization to photochemical ablation.
Which means the ultraviolet photons actually carry enough energy to directly fracture the molecular bonds of the plaque. You don't need a massive spike in temperature.
You're dismantling the plaque at a molecular level, turning solid tissue into microscopic gaseous byproducts. And because this energy is delivered in incredibly brief nanosecond pulses, the tissue has time to cool off.
The thermal relaxation time.
Exactly. Any residual heat dissipates before it can accumulate and damage the vessel wall, so you get precise ablation with virtually zero thermal spread.
It essentially transforms the laser from a blunt thermal weapon into a highly precise microscopic scalpel of light.
It does. But even with that massive leap in safety, the authors note that for a long time, ELCA was just considered a niche bailout therapy.
Right, it was the dusty machine in the corner of the lab that you only powered up when everything else had failed.
Yeah, but Gerardo Roman and Bazile highlight this quiet, highly impactful renaissance in contemporary PCI or percutaneous coronary intervention.
So what changed? Why is it suddenly a frontline tool?
It was a convergence of things. Catheter technology improved massively, so the delivery profiles became more flexible. They could actually navigate the twisty anatomy of the heart.
And the laser consoles themselves became faster to set up.
Right. In a heart attack scenario where every minute means permanent heart muscle damage, you can't afford a 20-minute setup time for a bailout tool.
And beyond the hardware, operators just get smarter about when to use it. The text isolates two primary targets today: balloon failure and heavily thrombotic or clotted lesions.
Let's really map out balloon failure for the listener because it sets the stakes perfectly.
Okay, picture this. You have navigated a tiny guide wire through a severe, heavily calcified blockage. The wire is your track. The standard move is to slide a deflated balloon over that wire and inflate it to open the artery.
But in a balloon uncrossable lesion, the calcified plaque is so dense and the opening is so microscopic that even the thinnest deflated balloon physically cannot fit into the space.
So you have a track, but your train cannot fit through the tunnel.
And that leaves the surgeon in an incredibly precarious position. If you can't advance a balloon, you can't deliver a stent. The whole intervention stalls.
Historically, that meant sending the patient for open heart bypass surgery.
Exactly. Or you have the balloon undilatable lesion. The balloon crosses, but when you try to inflate it, it just gets squeezed by a rigid ring of calcium. It won't expand.
The mechanical force of the balloon is useless against that kind of rock-hard density, and that is exactly where the laser comes in.
You advance the laser catheter over the wire, deliver pulsed ultraviolet energy directly to the front of the obstruction, and you modify the plaque just enough to alter its physical compliance.
You don't even need to vaporize the whole thing, right?
Oh, not at all. You just need to alter the structural integrity of the barrier so the balloon can finally cross and expand.
And it's a similar story for highly thrombotic lesions, where the vessel is choked with a massive acute blood clot. The laser vaporizes that clot burden without physically pushing it downstream.
Which is huge for safety. But, managing a technology capable of molecular ablation requires some serious rules. Which brings us to the core of the author's analysis.
The deconstruction of the classic 5S's.
Right. This framework was originally created by Egrid and Brilakis, and it was the gold standard for using ELCA. It was designed to maximize success while strictly limiting those early risks we talked about.
But as doctors logged thousands of cases, the absolute nature of these rules started to chafe against clinical reality. So let's look at the very first S selection of patients.
The old rulebook was very defensive. For example, unprotected left main coronary artery disease was a strict contraindication. You do not use the laser there.
Because the left main is the central pipe. It supplies almost all the oxygenated blood to the left ventricle.
Exactly. Any complication there, a tear, a spasm, results in instant, catastrophic hemodynamic collapse. The patient crashes.
So naturally, when the laser was still seen as unpredictable, you kept it far away from the most critical vessel in the heart. But the text outlines how this is completely inverted. ELCA is now increasingly used in left main interventions.
And the reason for this pivot is purely mechanical. The authors state that ELCA is favored in the left main because it allows for the simultaneous protection of side branches with a second guide wire.
Let's unpack the geometry there.
Yeah.
The left main often gets severe blockages right at its distal bifurcation, the spot where it splits into two other major arteries, the LAD and the circumflex.
Right. And if you're intervening right at that fork, any mechanical manipulation like inflating a balloon carries a high risk of physically displacing the plaque outward.
We call that the snowplow effect.
Yes, the snowplow effect.
Okay.
You push the plaque aside, and it instantly blocks the opening of the adjacent branch, completely cutting off blood flow to that part of the heart.
So to prevent that, doctors use a jailed wire technique. They put their main wire down the vessel they are treating, but they also lay a second safety wire down the adjacent branch.
That way, if the side branch gets snowplowed and compromised, you still have physical access to go in and save it.
And the magic of ELCA here is its compatibility with that two-wire setup.
Because the laser catheter just shoots light straight ahead, it doesn't have a high-speed rotating mechanical drill bit, so it can slide over the primary wire without grabbing, tangling, or shredding that secondary safety wire lying right next to it.
You get highly targeted plaque destruction at the fork while keeping an absolute failsafe in your side branch. That mechanical synergy is what turned the left main from a no-go zone into a prime target.
It's a massive tactical advantage. And staying with patient selection, we also have to talk about the calcification controversy.
This is fascinating. The old guidelines were super conservative about calcium. They said ELCA was only good for moderate calcification. Severe deep calcium was off limits.
The assumption was that photochemical light ablation is great for soft tissue and clots, but it just doesn't have the kinetic punch to break apart dense, rock-like calcium deposits.
But the clinical evidence has completely rewritten that rule. The authors point out that ELCA is now routinely used against superficial and deep calcium.
And for stent restenosis too, which is when blockages return inside an old stent due to scar tissue or calcified neotherosclerosis.
So why did they suddenly get confident about severe calcium?
It comes down to a deeper understanding of the laser's secondary effects. While the ultraviolet photons aren't cleanly vaporizing solid calcium like they do fat, the impact still causes profound structural changes.
It generates acoustic waves.
Exactly. Intense, localized acoustic shock waves. These micro shock waves ripple through the calcium, creating microscopic fractures inside the plaque's architecture.
You're degrading its structural compliance. It might still be sitting there in the vessel wall, but its rigidity is broken.
Right, which allows your balloons and stents to finally do their job. And for stent restenosis, the laser is perfect because it cleans out the tissue inside the stent without destroying the underlying metallic struts.
But, and this is a big but, the authors add a strong note of caution. It is still highly risky in small caliber vessels and severely tortuous, twisty segments.
The physics of those environments amplify the dangers. In a twisty artery, the laser catheter, which is somewhat rigid, has a hard time navigating.
Because it emits energy in a straight line from the tip.
Yeah, so going around a sharp bend means the tip is often pointing directly into the outer wall of the curve, instead of safely down the middle of the lumen.
And if you fire the laser while it's pressed against the wall,
you burn straight through the artery. It's a catastrophic perforation. And in a small vessel, your margin of error is basically zero. You can't maintain safe alignment.
Which perfectly sets up the second S in the old rule book sizing of the catheter.
The old rule was strict math. Never use a catheter larger than 2/3 of the vessel diameter.
And the logic there was based on those spatial constraints. Keep the catheter small so there's a buffer zone of fluid between the laser tip and the artery wall, protecting the healthy tissue.
But modern practice has moved away from that rigid ratio. It's now based on the specific shape and challenge of the lesion. The text highlights the 0.9 millimeter catheter as the modern favorite.
Because of its deliverability. When you have a microscopic residual opening in an uncrossable lesion, a larger 1.4 or 1.7 millimeter catheter will just hit the cap and stall.
The 0.9 millimeter has the sleekest profile. It can wedge deeper into tight spots, and the authors give us a really deep dive into its specs, which is super interesting.
Yeah, it operates at 80 millijoules per square millimeter. That's its fluence, or energy density. It fires at 80 hertz, so 80 pulses per second, and it has this unique cycle, 10 seconds on, 5 seconds off.
Which doctors find much more ergonomic than the 5 on, 10 off cycle of the larger catheters. But here is the real physics puzzle that the authors present.
Right, because at first glance, the 0.9 millimeter seems like the most powerful tool because its energy is so concentrated.
Exactly. It has incredible localized fluence. It acts like a highly focused drill bit, which is perfect for piercing the rigid cap of a blockage.
But the total cross-sectional area of that tiny pip is minuscule, so the actual volume of tissue it can modify in one pass is very small.
It's the difference between applying force with a stiletto heel versus a snowshoe.
I love that analogy. The stiletto, the 0.9 mil catheter, exerts immense pressure over a tiny area. It pierces easily.
But if you need to clear a wide path in a massive proximal vessel, the stiletto just drills a tiny pilot hole. It fails to achieve the widespread modification you need for a large stent.
So that's why doctors often choose the larger catheters for the left main or the wide proximal segments. The larger surface area delivers a vastly higher total volume of energy per pulse.
They create a much wider channel of structural modification. So catheter sizing isn't just about vessel diameter anymore. It's about the architectural goal of the ablation.
That is a huge shift.
Yeah.
All right, let's move into part 2 of our deconstruction, the next 3 S's settings, saline and speed.
Let's start with the third S settings. The operator's choice on the console. The old rule was the epitome of medical conservatism, a stepwise incremental increase in power.
Start at the lowest default setting, and if the plaque doesn't yield, slowly turn up the power and frequency.
The goal was to use the absolute minimum energy required to protect the vessel from acoustic or thermal trauma.
But Gerardo Roman and Bezel point out that modern reality is completely different. It's highly operator dependent now.
Yeah, that rigid stepwise approach is mostly gone among high-volume experts. Many of them choose to start at maximum fluence and maximum frequency right from the very first pulse.
Especially for stubborn, heavily calcified plaques.
And that isn't recklessness, it's an operator reading the clinical scenario. They know that low-energy pulses will just bounce off a heavily calcified barrier.
You're just wasting time and potentially causing microtrauma without actually modifying the plaque.
Exactly. It shows that real-world medicine is an art. It's about adapting to resistant plaques, not just blindly following a protocol.
Which leads us to the fourth S, the saline flush protocol. And this might be the most fascinating counterintuitive shift in the whole text.
It's definitely the most dramatic evolution. The original rule mandated that operators flush the artery continuously with pure saline while lasing.
The explicit goal was to clear all the blood and all the contrast dye out of the way. And the reason was to avoid a phenomenon called cavitation.
Let's explain cavitation, because it's crucial. When the high-energy ultraviolet pulses hit pure saline, the light just passes through. The laser acts purely as a photochemical cutting tool against the plaque.
But if those same pulses hit whole blood or dense radiographic contrast dye, the fluid rapidly absorbs the energy.
And that instantaneous energy transfer vaporizes the fluid, creating a rapidly expanding vapor bubble right at the catheter tip.
And within microseconds, that bubble violently collapses in on itself. That expansion and collapse is cavitation.
And that collapse generates intense, localized acoustic shock waves. In the early days, those shock waves were terrifying. Doctors feared the acoustic force would tear the delicate layers of the artery apart.
So the strict saline-only rule was born. Suppress cavitation at all costs.
And to be clear, that is still the manufacturer-recommended standard today, but the text highlights this off-label trick that experienced operators are using.
Like the aha moment for the listener here.
Yeah.
Experienced cardiologists will sometimes intentionally withhold the saline. They deliberately let the laser interact with blood or contrast dye.
They are intentionally inducing cavitation.
It's a brilliant inversion of the rule. Why do they do it?
Because when the light energy alone isn't enough to break a deep ring of calcium, they inject a highly absorptive fluid to trigger a localized acoustic detonation.
The cavitation bubbles generate shock waves that act as a force multiplier. They violently crack the deep calcium that the laser light physically cannot reach.
They turned a feared complication into a microscopic explosive charge.
But we have to reiterate the safety note here. The authors stress this is strictly off-label and requires massive expertise.
Oh, absolutely. You are intentionally generating kinetic shock waves inside a millimeter-wide biological tube. If you misjudge the volume of contrast, or if the tip is too close to healthy tissue,
the acoustic force can easily cause a transmural rupture. You blow a hole in the artery.
So it requires profound anatomical understanding. It perfectly encapsulates the shift from a novice following rules to a master manipulating physics.
Which is probably why the fifth S-low advancement is the single surviving original rule.
It is the unbreakable law of ELCA. You must advance the catheter at less than 1 millimeter per second.
The authors emphasize the why here. The Excimer laser is not a mechanical drill. It doesn't bore through tissue with rotational force.
No, it relies entirely on delivering photons to vaporize microscopic layers of plaque with every pulse.
So if an operator gets impatient and tries to manually push the catheter forward faster than the laser can clear the path,
You're no longer lasing, you're just using the fragile catheter as a blunt battering ram.
the physical tip impacts the hard plaque, and it can easily dive into the subintimal space and dissect the artery.
Plus, by compressing the tissue right in front of the laser tip, you change its optical properties. The energy absorption gets messed up, leading to inefficient ablation and rapid heat buildup.
The 1 millimeter per second rule ensures the photochemical reaction is always leading the physical advancement. Immense patience is required.
Okay, so we've torn down the old framework. Now we transition to Gerardo Roman and Bazile's proposal for 2026, the modern playbook.
The new 3 S's for complex PCI. Let's look at the first one, second guide wire compatibility.
We touched on this with the left main bifurcations, but the mechanical advantage extends to all complex PCI. The standard 0.014-inch guide wire is the foundation of the entire procedure.
It's the monorail that every balloon and stent tracks over. If you lose your wire position in a twisty complex vessel, the procedure is over. You fail.
And unlike other plaque-removing tools, ELCA doesn't jeopardize that track. Think about rotational atherectomy. That's a diamond-coated burr spinning at 160,000 RPMs.
If you run that high-speed drill into a vessel that has 2 guide wires sitting in it,
The rotation instantly grabs the second wire, It wraps around the drive shaft, tangles everything, and can sever the wire or tear the vessel.
But ELCA is just a catheter emitting light, no moving parts, so it safely tracks over the primary wire without grabbing any adjacent wires.
You can execute highly complex, multi-wire bifurcation strategies without losing access to crucial side branches.
But the authors do highlight a very specific, fascinating warning here. You have to be extremely cautious with polymer-jacketed wires.
Yes, a polymer-jacketed wire has a core encased in a smooth, slippery plastic sleeve. They are amazing for navigating tight microchannels because they are so steerable.
But the ultraviolet energy of the Excimer laser has a highly destructive chemical interaction with that plastic coating.
If the laser fires while touching that polymer jacket, it rapidly melts and ablates the plastic,
And if you advance too fast and scrape the wire, that plastic jacket strips off.
which is a nightmare. The stripped plastic can wash downstream and block the microvessels, or the sticky, melted remnants can actually cement the laser catheter to the guide wire inside the patient's heart,
It's a severe complication. You really have to know the material science of every tool you're using.
which leads right into the second new S support. Because what good is a laser if you can't push it to the target?
Exactly. The complex, calcified anatomy creates so much friction. If your support system is weak, the delicate laser catheter will just buckle or kink in the vessel before it ever reaches the blockage.
So support starts with the optimal guiding catheter, the large outer tube seated at the origin of the artery. It acts as your foundational anchor.
And the authors mention anchoring techniques that are uniquely feasible with ELCA.
Because there's no spinning drive shaft, you can push a secondary wire into a nearby side branch, inflate a tiny balloon to lock the whole system against the vessel wall, and use that leverage to push the laser forward.
But the real game changer they discuss are guide catheter extensions.
These are smaller, flexible, telescoping tubes that slide through the main guide catheter and extend deep into the artery, bypassing all the twisty proximal segments.
They deliver their tip just millimeters away from the lesion. They act as a physical scaffolding, a smooth tunnel that shields the fragile laser from friction.
But they have a secondary function that is absolutely critical, and it perfectly aligns with the title of our show.
The funnel effect.
Exactly. We talked about how crucial it is to control the fluid environment, whether you're flushing pure saline to stop cavitation or injecting contrast to intentionally cause it.
If you try to inject those fluids from way back at the origin of the artery, the fluid gets diluted or washed away by the blood flow before it reaches the laser tip.
But the guide extension solves that. It acts as a focused funnel.
You inject the saline or contrast through the extension, and it delivers a highly concentrated volume directly to the tip of the laser.
It displaces the blood flow, giving you absolute microscopic control over the fluid environment exactly where the physics are happening.
It's brilliant. Which brings us to the final new S. And this is where the real tactile art of surgery comes in. Sense early, switch wisely.
This is so important because ELCA is fundamentally different from other tools. If you use a rotational burr, you physically feel it break through the resistance.
If you use intravascular lithotripsy, the sonic balloon, you literally watch the balloon expand on the monitor as the calcium cracks.
But ELCA is an invisible intervention. The effects are microscopic, and because you're moving at an agonizingly slow 1 millimeter per second, you get almost zero tactile feedback.
So the sense early mandate is all about continuous assessment. You can't just pin the laser against the blockage and hold the pedal down.
The authors advise alternating gentle forward and backward movements. You advance a fraction of a millimeter, feel the resistance, pull back to let the microbubbles clear, and gently advance again.
You're meticulously interrogating the tissue, feeling for unseen changes in compliance.
And here is the true magic trick of ELCA that inexperienced operators often miss. They assume the laser failed simply because the catheter never physically pushed all the way through the lesion.
Right, but you can dramatically modify the plaque without the catheter ever fully crossing it.
You might fire the laser against the cap of a 5 millimeter calcified blockage. The laser might only penetrate 1 millimeter before stalling. To the eye, it hasn't crossed.
But the intense energy, the photochemical ablation, and those acoustic shock waves have fundamentally altered the entire 5 millimeter structure.
It created microfractures. It softened the door.
So if the operator senses early that this happened, they pull the laser out, slide a standard balloon over the wire, and suddenly the balloon easily slips through and dilates the lesion.
The laser didn't clear the path. It just altered the physical state of the blockage enough for the standard tool to work.
Knowing when that happens requires immense procedural maturity, and that ties right into switch wisely.
Right, because Gerardo Roman and Basil emphasize that ELCA is rarely a standalone cure. It is a highly specialized preparative tool. You have to know when to stop lasing and seamlessly combine it with other therapies.
The text details two ultimate combination therapies, Razor and atherectomy. Let's unpack Razor first. It stands for rotational atherectomy plus Excimer laser.
Imagine the most hostile anatomy possible. A twisty artery choked with a massive, impenetrable block of calcium. A balloon won't cross.
So you deploy the 0.9 millimeter ELCA catheter. Its high focal fluence drills a microscopic pilot hole, letting your guide wire finally cross.
But that 0.9 millimeter hole is way too small to actually fix the artery, and a larger laser won't fit through the twisty vessel. You have a wire across, but essentially no channel.
This is where you switch wisely. You pull the laser out, keep your wire in place, and advance the high-speed rotational gun over that same wire.
The laser served one specific function, creating the initial microchannel. The drill then uses that track to aggressively widen the path and grind the calcium away.
It's the perfect synergy. Light to pierce the armor, mechanical force to clear the bulk.
And ELCA trypsy follows the same logic, combining ELCA with intravascular lithotripsy.
Lithotripsy uses that sonic balloon to crack deep calcium rings. But the balloon is bulky. If the lesion is uncrossable, you can't deliver the sonic balloon to the target.
So ELCA acts as the vanguard. The laser vaporizes the surface plaque, alters the compliance, and opens the door.
Then you switch wisely. Pull the laser, advance the bulky lithotripsy balloon into the newly created space, and deploy the sonic waves to shatter the deep calcium the laser couldn't reach. Mastering ELCA isn't just about the laser itself, it's about knowing how it interfaces with every other physical and sonic tool in the lab.
It really is a remarkable synthesis of technology. We've spent this hour tracing the evolution of a highly specific medical intervention.
We saw it start in the 1980s as this dangerous, heat-producing infrared laser that was just a terrible fit for human biology.
Then the pivot to ultraviolet, cold photochemical ablation.
And then we watched seasoned experts systematically rewrite their own defensive rulebooks.
Expanding into the left main, targeting deep calcium, weaponizing cavitation using contrast dye, and building these massive multi-tool combination therapies.
It shows that mastery in any field isn't about blindly following the original 5 S's. It's about understanding the materials and the physics so well that you can adapt the rules when the situation demands it. Understanding the why lets you safely manipulate the how. Now, as we bring this deep dive home, we want to leave you, the listener, with a final provocative thought.
This builds on what we were just talking about, the magic trick where ELCA modifies the plaque without even crossing it.
Right. If laser energy and acoustic shock waves can alter the physical state of a severe blockage from a distance, allowing standard balloons to suddenly work, what does this mean for the future of non-invasive therapies?
It's a huge question. Could we eventually see purely contactless internal surgery?
Imagine a future where we don't need to navigate complex wires and bulky catheters deep into the microscopic pipelines of the heart.
Where highly focused energy waves, maybe advanced light or precision sonic arrays or frequencies we haven't even invented yet, do all the heavy lifting from a standoff distance.
They remotely alter, dissolve, or structurally modify the diseased tissue ahead of any physical tool. It fundamentally changes how we clear the human body's pipelines, eliminating the physical risks of pushing hardware through fragile biology.
It sounds like sci-fi, but based on the acoustic and photochemical modifications we unpacked today, we are arguably already on that trajectory.
The distant future of interventional medicine might be completely contactless.
Achieving maximal therapeutic impact with zero mechanical footprint. It's an incredible thought.
Thank you for watching The Funnel Effect.